What an information-packed day today was. So much to consider. I thought I'd start today by sharing a personal story. I lost my father this past year. He was 92 years old. He had fallen. He went to the hospital. He had successful surgery to repair his broken bones. He was awake and alert for 2 days. And then he started to experience hospital onset delirium until his passing. 30 days from start to finish. 30 days from still doing chemistry consulting work with pharmaceuticals until he passed. It's absolutely could be argued that the healthcare system we have today is what enabled him to live such a good life, contributing to the greater good until his body no longer could. But there's part of me that wonders if the hospital where he had sought care had practices similar to what was discussed today, couldn't he have squeezed more time out of his body and into his life? And I mean, I was just blown away by today. I think that if he had received any piece of the level of care that was being discussed, it potentially could have been a different outcome. As we age, our lives increasingly become filled with healthcare appointments. From the perspective of the mean and the mode of who most often is served by our healthcare system, you would think that of course it would be age friendly. Unfortunately, what drives the delivery care so often is not the patient, but the payment system. That's why healthcare systems need special initiatives like patient and family engagement practices and age-friendly health systems. I'm so glad all of you were here today to be able to learn together, brainstorm, pick up new ideas to bring them back to your organizations. So the New Hampshire State Commission on Aging, it potentially is an entity that can help refocus the other drivers of the healthcare system and health overall. The New Hampshire State Commission on Aging is not only an opportunity to influence payment policies, but also other public policies that influence well-being and how we age in the community of our choice here in the Granite State. But it's a new initiative and within the state government, and it will really take all of us to make it something that's meaningful. The commission needs to hear from people like you about what issues you feel are important, and to learn from you, to learn from your expertise, not only as healthcare providers, and but also from your experience living here in the Granite State. I'll use my time today to talk a little bit about the commission and what we're currently focused on. Through this overview, it's my hope that you can begin to see how the commission might be able to impact the people that you serve. And then I'll wrap up my talk by talking a little bit about the elephant in the room, that topic of ageism. Raising awareness about the impact of ageism upon all of us is really one of the overarching missions of what the commission is setting out to do. Next slide. So as I mentioned, the commission is a neat new initiative. It first convened in the fall of 2019. I began my role in January of 2020, at the very last day of January. And just a few short months after that, we started all to feel the impacts of COVID. It's really been a whirlwind since. The creation of the commission was really due to advocates who felt that the various state agencies that had roles in helping us all to age in the community of our choice were really not, there wasn't enough coordination between state agencies in order to really do that job in an effective manner. So it was in this 2019 legislative session that a bill was signed into law creating the State Commission on Aging. Next slide. So here is just a taste of some of the demographic data that suggests that we need to that more attention needs to be paid to our aging population. I really don't want to spend a whole lot of time on demographics. I just want to share a few pieces here to say that New Hampshire, like the rest of the country, the rest of the world, it's growing older. The percentage of growth is increasing for ages 65 plus through 2030. The oldest of the old, the 85 plus category, continues to grow at a very high rate through 2050. Bottom line, by the year 2030, it is estimated that over 1/3 of New Hampshire's population will be over the age of 65. Next slide. Who is the commission? As laid out in the statute, we are a 26-member body. From the New Hampshire State Legislature, we have 1 senator and 2 representatives. We have written into the statute our state eight state agencies to participate on the commission. And then there are 13 community members from all 10 counties. The original group of community members, they're all appointed by the governor. The original group came from the makeup of the State Committee on Aging that was positioned to advise just only DHHS and went away with the creation of the commission. Going forward, openings will be considered by the commission, and we will make recommendations to the governor for him to consider making an appointment. We really do strive for a mix of professionals in the field of aging, as well as community members who can bring that community voice to our work. It's really that idea of nothing about us without us. We currently have an opening in Stratford County. If you know of a good person that you think might be great for the commission, I welcome for you to connect with me after this presentation. We welcome public attendance at our meetings. This group meets monthly on the third Monday of the month from 10 to noon. There's always a Zoom link. Right now, we're all remote. So there's a Zoom link that is available on our web pages. At the very end of my slide deck, there is a link to our web pages. So you'll get the slide deck and be able to go see it. Next slide. So this is a long list of the commission's duties as they are outlined in the RSA. I'm really not going to read through it, no worries. It all comes down to the fact that the commission is set to advise the governor and the legislature on aging issues. The charge laid out here tells us what we can influence, but it really doesn't set any sort of priorities or issues that we should specifically dive into. So next slide. So last spring, just a few months into my tenure, we engaged in a strategic planning process. Next slide. And the sum result of that was this strategic map that we finalized in August 2020. We developed standard things that you would in an organization, our vision, our mission. For the commission, we outlined values to guide our work, and then we set strategic priorities to chart the course of our investigation for our first 3 years of existence. I'll take the next few slides to break it down for you. Next slide. So very simply, our vision is for all people to have the opportunity to thrive and be valued while growing older in New Hampshire. And our mission is to be a catalyst for change that values, serves, and celebrates people as they grow older. Next slide. To touch on our values, we want to be forward-thinking, we want to collaborate with others, we want to take advantage of all the expertise that exists across the Granite State. Public trust and stewardship of New Hampshire resources is critically important to the state-sponsored group. And finally, we want to maximize opportunity for all and engage all the talents of older people in New Hampshire to create a better future. And again, it's really owning that concept of nothing about us without us. Next slide. So the center section of our strategic map lays out our priorities for the first 3 years. We've established task forces for each of these priorities that meet monthly. The information on those meetings is also available on our web pages. And again, we welcome you to come and share your expertise. Being a new entity, we really do have a lot to learn. Next slide. I'm now going to dive into the details of what each of the task forces are doing. So the Aging and Communities of Communities of Choice Task Force is focused on developing and advancing strategies to improve people's ability to age in the community of their choice. This group is beginning to narrow its focus on the accessibility of long-term services and supports that allow us to age in our home. Housing and transportation, which repeatedly come up on any survey of older adults as top issues of concerns about being able to age in your home, will be interwoven into this review and investigation into this area, as will be, hopefully we'll be able to address workforce issues as well, all as they impact the accessibility of long-term services and supports. In New Hampshire, as we age, choice of setting to live can become a challenge. There's really no clearly defined system of care. Workforce shortages and reimbursement schema result in limited availability of services. For example, the AARP Long-Term Services and Support scorecard ranks New Hampshire 32nd in our capacity to provide adult day services. Public awareness of services is also limited. Care coordination, care management supports are finite, and care is expensive. Next slide. This slide has data from Kaiser Family Foundation that names the median annual cost of care by types of service. You see there's nursing facilities, home health aides, adult day services. Forget about the orange line, or it might be yellow line on your screen, that marks the federal poverty level. How many of any of us could afford these annual costs of care for ourselves or our loved ones? According to the AARP Long-Term Services and Support State Scorecard, New Hampshire's percent of Medicaid spending going to home and community-based services for older people and adults with disabilities was only 14% in 2016, resulting us being ranked 50th amongst all our fellow states. Payment structures support facility-based long-term care in such a way that it really has become an entitlement, whereas home and community-based services, even though they're cheaper, really are not. It's the payment structures that make it easier for hospital discharge planners to discharge somebody to a nursing facility rather to into the home, based on the fact, if they need daily functioning support. It's just easier to discharge somebody to a nursing home rather to send them home and arrange for all of the appropriate supports that they need in that location. I don't mean to speak for all the discharge planners out there. I know it's a Herculean job that you do. Next slide. So housing and transportation will be addressed more head on by this task force. This is the Age-Friendly State Task Force. This task force is learning from age-friendly community initiatives led by in local communities in New Hampshire to learn about what's working in New Hampshire communities and what can be done at the state level to support local community efforts. Age friendliness is a term that's been coined by the World Health Organization and promoted in the United States by AARP. The AARP framework for age friendliness suggests 8 domains ripe for change that could help make a community more age friendly. It suggests a process, not a certification or end goal. It's very much like the age friendly health systems model, where communities start by picking domains to do an assessment of their community. And through that assessment, they come up with their own ideas about what they want to improve in that community and begin to work on them. This task force will also consider ways to start working with various state agencies so that they can do their own self-assessment about their own age friendliness and basically with the availability and supports to access their services. Okay, next slide. We also created a task force to attend to the rapidly shifting policies in response to COVID-19. The 3 broad areas listed on the slide, ageism, socialization, and long-term care systems, was where we decided to focus our attention. For instance, we looked at visitation guidance in long-term care facilities. We've advocated all summer, last summer long, for some expansion there, knowing how social isolation can lead to increased morbidity and mortality. We also looked at broadband access. We discussed senior centers and their reopening. We looked at the vaccination strategies that the state was embarking upon and more. As we approach the tail end of this pandemic, I imagine that this group will likely seek to capture what we have learned from it. What vulnerabilities of our systems of care did this virus expose? What changes we made throughout the pandemic do we want to keep post-pandemic? And what new ideas do we need to consider and invest in to reduce the impact of future epidemics? Cross your fingers, there isn't one. Okay, next slide. This final task force, the Operational Infrastructure Task Force, really serves as the executive committee for the State Commission on Aging. It addresses elements of operations that are not attended to in the RSA, develops the monthly agendas for the overall commission, and seeks to be responsive to what's happening in the state legislature. Next slide. So the statute that created this State Commission on Aging requires that we submit an annual report each year in November to both the governor and the state legislature that includes a list of recommendations for change. Its content is largely based on what occurs during our monthly meetings of the full commission. I'm not going to go into the details of what is in our last year's report. I'll tell you, it was our first year of being in operation. It's pretty high level stuff, but it really does suggest a good direction. The links are there so that when you get the slides, you can review them on your own after this presentation. Next slide. So what I want to spend the remaining portion of my time is to talk about ageism. Overlaid over all the work that the Commission does and will do is an effort to change the narrative on aging. Our goal is to bring awareness to the impact of ageism on all of us. We all want to live well and live in communities that help us to live well. Yet, according to a new World Health Organization global report on ageism that was published just this past March, every second person in the world is believed to hold ageist attitudes. I'm just going to say that one more time. Every second person in the world is believed to hold ageist attitudes. Next slide. So what is this? What's behind this? It's really about implicit bias or unconscious bias. I was hoping to be able to have a gallery view to ask you to nod your head if you had heard either of these terms before, but no worries, I'm just going to go ahead and explain. So unconscious biases are beliefs and responses we are conditioned to have based upon our lived experiences, from what we're exposed to in the media to what we were exposed to as we were growing up, from all of our interpersonal actions every day. It's really in the air that we breathe, it's in the water that we swim. This unconscious biases is what allows us each day to act quickly in very familiar situations. Being primed at the checkout aisle of the grocery store to be able to have your credit card handy or cash to pay. It can be very good. A car is barreling down the street at you. You don't even think, you jump out of the way. Keeps you safe. But not every scenario is as straightforward. These ways of thinking that are really under the water of our consciousness are driving our behavior and can get in the way of what we really want to achieve. So unconscious biases are more prevalent and more powerful than our conscious thoughts. They're really baked into our culture and are reinforced continually. They often directly conflict with what we consciously, actively believe and express and strive to achieve each day. So to test this out, I thought, imagine an 80-year-old person and his or her health. If you can put into the chat the first word or phrase that comes to mind, an 80-year-old person and his or her health. And I'm going to swoop over here to the chat so that I can just take a quick peek. I can get my mouse to work. Oh, complex. Healthcare provider, definitely. Needs help, walking. This is an 80-year-old person and his or her health. You can throw it into the chat. Slipping, between independent and decline, varies, frail. Okay, so I'm just going to tell you that you are a very optimistic group. I've done this before. I've not had such a, I mean, you know, not that there isn't caution in this, but it's usually even more negative than this, than what's in the chat. So that's pretty impressive. So, so now I just want you to think, imagine yourself as an 80-year-old person and your own health, and just, you know, what more did you know, what first word comes into your mind? Did it change? Did your answer change when you're considering yourself as an 80-year-old and your health? You don't have to answer that in the chat. It's just throwing it out there. So ageism is said to be the only ism in which we discriminate against our future self. If you still believe that you are immune to this, I suggest you check out the link on this page to the Harvard Implicit Association tests. They have tests for most isms, racism, whatever you can think of. They pretty much have a test for, including one on ageism. And I will tell you flat out that I come up, after taking this exam, you know, I come up as being ageist. There's no question about it. And I can name probably all sorts of factors that relate to this, including the fact that I lived, my parents lived far away from either of their parents. And so we rarely saw grandparents. And so I was never really exposed when I was growing up to positive role models of people aging. Next slide. Okay, and I just need to lose my chat. I think it's fine. Okay, so what's the problem with this? Unconscious biases drives our thoughts, feelings, and actions. And from that, it gets incorporated into our institutional policies, comes out in our interpersonal interactions, and it becomes internalized. Next slide. So let me focus a little bit on the self-directed internalized ageism that happens and impacts our health. Here I'm going to share some research that I'm still learning about. Becca Levy is a Yale researcher. She is at the Yale School of Public Health. She also has an appointment within the Department of Psychology, and her research explores psychosocial factors that influence elders' cognitive and physical functioning, as well as their longevity. She's credited with creating a field of study that focuses on how positive and negative age stereotypes, which are assimilated from culture, can have beneficial and adverse effects, respectively, on the health of older adults. So she talks about the stereotype embodiment theory, which basically says that age stereotypes embodied when internalized from culture leads to self-definitions that influence functioning and health later in life. Age stereotypes can be assimilated in children as young as 4 and are reinforced across the lifespan, and that age and stereotypes impact health by operating unconsciously. Those are all the things that we just talked about. Next slide. So one study she contributed to provided evidence that age stereotypes held early in life can predict cardiovascular events later in life. If you look at the red line on this slide, you'll see that it's pointing to people who have positive age stereotypes and their experience with first cardiovascular events. And the blue is folks that have negative age stereotypes and their cardiovascular events. Next slide. Another study she contributed to made the association between positive age beliefs and resistance to dementia, both in study participants with the protein implicated in Alzheimer's disease and in study participants, including those without the protein, with and without the protein. So you'll notice the framing on this slide of how the slide is described, that it puts the uses a positive opportunistic perspective for improved health outcomes rather than coming from a negative association of barriers to well-being. Remember that for when I get to my final slides. Next slide. So just to bring this all home, there are at least 6 different meta-analyses out there that replicate findings that age beliefs impact older person's health. The meta-analysis suggests that ageism influences through numerous pathways, including psychological, behavioral, physiological, sociological, economic, and a few other pathways probably too that I just didn't mention. Next slide. So ageism affects not just health, but healthcare too. Healthcare seeking behaviors are impacted. This is conditions like depression and pain may go undiagnosed and treated. Reversible causes of problems like memory loss and mobility are overlooked. Conditions like prostate cancer may be overtreated, leading to unnecessary harm. A little personal story here, my, at the time, 91-year-old stepmother who hadn't had a breast cancer mammogram, thank you, in decades, decided to get a mammogram. There were some cancerous cells found, and through consultation with their doctor, chose one of the most aggressive treatment options possible, something that you would think that would be for a 35-year-old patient, not a 91-year-old patient. It was a very aggressive chemotherapy before surgery. She did not respond well to the chemotherapy, and really, she went from a person who was painting, standing up at an easel almost every day, and it's been 4 years since, and she hasn't picked up a brush since. And it's you have to wonder. So patients may be less likely to seek healthcare when needed, is the inverse of that. And patients may be less likely to engage in preventive health behaviors. Next slide. So provider organizations and provider behaviors are affected as well. In clinical encounters, physicians dismissing a treatable pathology as a feature of old age, or treating the natural effects of aging as disease, both ways. There's undertreatment of pain. There is healthcare providers can sometimes do communicate differently with older people. They use elder speak, really unknowingly patronizing older adults without meaning to. It includes speaking slower, more simply, which absolutely can work a bit with somebody with speaking slower with somebody with a hearing deficiency. But also calling folks diminutive names like honey and sweetie. It's all very well meaning, but very misguided. So all of this, really all of it, leads to poorer physical and mental health and reduced quality of life for older persons, costing billions of dollars each year. Next slide. So back to the research by Becca Levy. She and others found that the total cost of ageism for older persons in the health in the United States in 1 year was $63 billion after adjusting for age, sex, and removing the overlapping costs from the 3 predictors on the slide here. More than the annual cost of morbid obesity in this country. Next slide. So what can we do about all this ageism? First, we can take steps to manage our own unconscious biases. Spy on yourself. What did I just do versus what do I want to do? Call yourself out. Identify your triggers. Are there certain things that happen over and over again that elicit an immediate response that you often regret afterwards? If you can identify your triggers, you can stop your next action. Slow down. If you've ever heard of the stop mindfulness technique for managing stress, it works well at managing your implicit bias too. It allows you to pick another strategy rather than the one driven by your unconscious mind. Next slide. Regarding our own and our patients' implicit bias, Rebecca Levy, back to her again, she did a study that looks into the influence of a positive image of aging intervention. So it's a specific intervention focused on presenting images of positive aging on an older person's physical function. She had she had about 100 individuals, I believe it was, that were randomly assigned to an implicit positive age stereotype intervention, an explicit positive age stereotype intervention, both or neither. And the interventions occurred at 4 one-week intervals. There was improvement in physical function that continued for 3 weeks following the last intervention session. I think that's the last time that they actually measured to see if there was improvement. Basically, what she found is that what we see around us does absolutely impact our biases, and that it can be modified through various interventions that seek to create positive age images in our brain. So I'll tell you, the implicit intervention involved presentation of implicit positive age stereotypes in multiple community sessions, and the explicit positive age stereotype intervention was based on a conscious imagery technique. So it's an interesting study. I probably didn't do it justice. It's definitely worth going to check out. I did put the links to all the studies I talk about on this slides. So next slide. So the World Health Organization Global Report suggests the following avenues for combating ageism. It suggests addressing policy and law. And when they talk about policy, they mean big P and little p. So there's governmental, federal, state, and local law, but also the little p policy about the rules that guide our organizations. They suggest educational activities that can transmit knowledge and skills and enhance empathy. And they suggest getting involved in intergenerational interventions that can connect people of different generations. That's really about exposing people to diversity. Next slide. I just also want to say that the global report on ageism, if you go to the World Health Organization, they do have a number of resources available on their website that are a little bit more specific than what I just suggested in that last slide. So the John A. Hartford Foundation, which you heard about many times, I think earlier today, that supports age-friendly healthcare, suggests that to only work in our health systems is not enough. You have to only work in our communities. That's not enough either. We really need to do all of it. We've got to take care of the entire ecosystem. Next slide. So we can do this together to reap the societal benefits of people living longer, often referred to as the longevity dividend. We need an aging attitude adjustment. Older age, like any other time in life, involves both challenges and opportunities. And the future is a time for improvement. Please help me connect the Commission on Aging to your work and be a megaphone for it, and to help develop an age-friendly ecosystem here in the Granite State. So thank you for your time at the end of this very long day. My next slide, if you want to go to it. It has numerous acknowledgments of the materials that I covered here today. I confess to be on a learning journey myself on all the topics that I raised. More than happy to try to answer your questions now. I also do want to put in another plug for the John A. Hartford Foundation. It's well worth going to their website and seeing what resources that they have. There's some really good stuff there.